The title of this session is Accelerating Innovation and Collaboration in the Power of 5G. I think what we're really going to be talking about in reality is about partnerships, the power of partnerships, transformation or transformative change at pace. I think we're going to be talking about the use of technology, but it's technology that's already here. The innovation that we're talking about is not the technology. I think the innovation is the use of technology and its immediate application. And I suppose the backdrop for that is COVID and the opportunity that COVID has created for all of us to drive change and think differently. So before I say any more, my name is Tony Stevens. I'm the interim chief executive in Northern Ireland of the Regulation and Quality Improvement Authority. I'm just going to introduce our speakers first. So I'm going to let them introduce themselves and start with Andrew.
Hi, my name's Andrew McCurgan. I'm a Chief Officer for Out of Hospital Services at University Hospital Birmingham.
Hi, I'm Janice Bailey. I'm Assistant Director of R&D Division in the Public Health Agency here in Northern Ireland.
Yeah, hi everyone. Lucy Baker, Service Technology Director in BT, in the Enterprise organisation in BT.
Before we go any further, Lucy's going to introduce a very short video that I think is a segue into the wider conversation. It demonstrates really very eloquently in 3 minutes what the basis upon which we're going to take our discussion today. So Lucy, back to you.
Thank you, Tony. I think a large part of my role in BT is to explore early 5G use cases across the healthcare sector. And this involves working closely with colleagues across the NHS to drive forward and prototype and proof of concepts and collaborating on those. And this video, as Tony said, is a short video which shows, the first proof of concept that BT worked together with University Hospital Birmingham in terms of 5G connected ambulance.
Activated.
One of the main things you do as a paramedic is go to environments that we can't control. There's always a sense of interpretation as you approach. If we can get on top of things faster, that is going to save some lives.
5G is a cutting-edge technology. It's mainly focused on mobile, and it's got 3 major characteristics: speeds above 1 gigabit per second, massive connectivity, and the third one is low latency. In healthcare, we can imagine live transmission and sharing across 2 different locations between a clinician and a medic.
5G to us in healthcare is much more than just a faster 4G. It allows us for the first time to use high-definition video to transmit images of patients, images of their conditions, and also we can use it to transmit high-definition images of ultrasound.
It's amazing how people started working together, and in a couple of months we had the first ultrasound test that we did over 5G. We have now, a connected ambulance and capability to do a real-time diagnosis.
I place the haptic glove on my hand, I do my ultrasound as I would anyway. Doc, I'm wondering if I could run something by you for a minute. The physician moves the joystick left, it will vibrate and I'll move my hand left. In the back of the ambulance, we also have a 180-degree camera. Using the virtual reality headset, the doctor back in the hospital can see a view of the back of the ambulance. That's directly linked to the ultrasound and the vital statistics. Using the augmented reality headset, I can show them what I'm actually looking at. Zoom 2. It's all audio commands, so I'm not even touching the headset. The 5G project is essentially like having an entire specialty suite within one environment. I can already phone them, but if we can get on top of things out in the community faster, it'll free up beds.
And in this particular case, in which the patient is bleeding into their tummy from their liver, allows us to make sure that they come to the right hospital at the right time, so if necessary, they can go straight into liver surgery.
It takes 15 years plus to train doctors to do some of the stuff we do here. The ability to increase the capacity of our workforce is limited by the length of time of their training. There's a huge area where technology can simply fill that gap.
I think it will be a game changer. I think it will be part of a process in which the NHS and other healthcare systems start to move into adopting new technology to improve the delivery of healthcare to very large numbers of patients.
5G opens a new culture of collaboration to transform these industries. It's not just to do it differently, but is to provide more added value.
Without embracing technology, there is simply no way we're going to keep up with demands being placed on the service.
Midwives, district nurses, pharmacists, they're all able to benefit from this 5G network, ultimately delivering better healthcare and making a big difference to more people's lives.
So the engagement with the companies delivering the connectivity is hugely important. It is the only reason that we've come as far as we have, both in terms of what we've already done, but certainly in terms of what the world could look like in a few years' time.
Using the 5G network of BT, we are transforming the way that healthcare is provided, and we want the Queen Elizabeth University Hospital of Birmingham to be the lighthouse for the UK and for the NHS.
Thank you. I mean, I think that video demonstrates what we all know and what we all aspire to in terms of the use of technology. Andrew, Lucy, I think we all have experience of working in health, for those of us who work in health and social care, of the relationship with tech firms not going well. And I suppose that's a fairly topical issue at the moment in terms of test and trace. Maybe you just explore for us how you got your partnership going, where the vision was, and how you built a productive relationship that started to deliver for you. And maybe then just explore a little bit where you're going with that.
We've been working closely with UHB for the last 18 months. And I think, it was very clear from the outset that with the Chief Executive, Dave Rosser, and our CDIO, Fotis Koronis, the important thing was actually that partnership and working together. And, we decided to sort of collaborate on proof of concepts. And it was a bringing together of that sort of technology expertise, but that combined with the clinical expertise, the knowledge of the care pathways and the operational adoption. And it's proved to be a really successful formula. It's not about BT, so the tech companies developing something independently and then chucking it over the fence at the trust. This is about us working hand in hand every step of the way together. And, I think it's proved to be a really successful model.
I think going back to the question, one of the challenges I think is that a lot of organisations are inundated with tech from lots of different tech companies, but we don't always, as a system, have a sort of coherent strategy around really harnessing digital technology and innovation. And certainly in Birmingham, we've been, as a system, very fragmented, both in terms of health delivery, multiple organisations, and also local authority. And therefore, it's been really difficult to really progress it as a dynamic sort of strategy, because everyone's sort of trying to dabble and do their own thing and not really clear how to really truly harness the benefits of digital. And I think the approach we've taken with BT, I think, is really recognising that actually you need to do this type of transformation in partnership and collaboration, both across health organisations, but also with somebody like BT, because what you want to do is really design transformational new models of care and ways of working in partnership with with a provider like BT, to make sure that actually what you're designing really actually is underpinned by the best digital technological fit, and actually it's fit for purpose. People will use and not leave in a cupboard because somebody dropped it into them on a day and said, go away and use this bit of tech. And I think that's got to be core, is that you're doing things in collaboration and actually you're working with the frontline staff to develop new ways of working and developing the technological components of that as you're going along.
And I think, Andrew, what's really exciting is the fact that this isn't just BT working with UHB. The virtual group extends to the Ambulance Trust, Birmingham Community Healthcare, early intervention teams, GPs, so, a broader engaged group coming together. And I think that's what works well, because you say a lot of these technologies and concepts have been around a while, but if you've got the culture and the mindset and everyone's heading in that direction, it makes it a really successful path to follow.
Yeah, I think that's right. And what was interesting is that a lot of the challenges that we face and are around demographic, they're around lots of frail elderly, multiple people with chronic conditions. And some of the challenges of stopping a lot of patients sort of arriving in accident emergency, large numbers of emergency admissions, is actually how we join up different elements of what to now has been a very fragmented health and social care service. So using that technology, for example, to link up your specialist geriatrician-led MDTs at the front door of a hospital with intermediate care bed centres, community teams looking after the frail elderly, and starting to connect them up, not just with video, but with the opportunity to use digital devices. Also, the same principle applies to care homes. It's a really exciting way of really changing healthcare delivery and being able to decentralise care and provide specialist support to people out in the community and out in people's own homes, which potentially enables them to remain independent.
And I think that was really the kickstart to the work that we did on remote diagnostics, Andrew, wasn't it? Because I can remember back at the sort of towards the beginning of the COVID pandemic that Dave Ross, the chief exec, called us all into a room to say, look, what could we do in terms of providing some form of capability to be deployed? And they were setting up the Nightingale Hospital at the NEC. And what could we do in terms of setting up a remote diagnostic capability that could support the clinical staff at the hospital, and also that could address, as Andrew just said, address the concerns around caring for the elderly out in the community. And so that was a sort of second big piece of work that we've worked on together, which is a development of a remote diagnostic capability to connect, as Andrew said, health professionals, in the field back to clinical experts back at the hospital.
And I suppose, Andrew, I'd have a question for you. In these COVID days, have you, because these projects started before COVID, have you accelerated any aspects of the work specifically to respond to issues like patients being reluctant to come to hospital, or GPs being reluctant or unable to go into care homes? Have you put that bent on things at this point?
Yes. I mean, we've set up a link with the paramedics. So we've now got the paramedics across Birmingham now have the opportunity to link into our front door frailty team, our Opal team. And we receive probably about 50 to 60 sort of video calls a week. And the conveyance rate is about 26% following those calls. What we're now starting to develop with BT is how do we advance that and start to bring in some of that digital device diagnostic capability into that type of model. We've also trialled, as I think you're aware, a link with BT with one of our intermediate care centres back to our front door team, and are looking to roll that out across the remaining intermediate care centres between now and probably January, and that's in partnership with our community trust who are on board with that. It'll also actually in parallel allow us to start to review and redesign, for example, our medical model cover across acute and intermediate care for older people. Because at the moment, everybody has consultants in all of these centres, but how could we potentially centralise specialist input and then link that specialist input up to community teams via video with diagnostics? And that's something that as organisations we're keen to explore. And we're also in discussions with a number of PCNs aligned with the network contractual specification around enhanced support to care homes about how we can actually start to set up digital links in partnership with GPs and some of the care home providers they're aligned to set up those new ways of working.
Maybe, Tony, we'd like to maybe talk through a little bit about the kit itself. So we talk about some remote diagnostic capability. This, in essence, is a sort of it's a kit that consists of sort of market-leading medical digital devices such as digital stethoscope, ECG, ultrasound, and uses our converged network, so be it 4G, 5G, Wi-Fi, to be able to connect to healthcare professionals, a community nurse in the field back to a specialist at the hospital. It also has a see what I see camera capability, so the clinician back at the hospital can see what I see from the patient's bedside. So not only can the nursing staff in the care centre that Andrew talked about place the stethoscope on the patient, the clinician and the specialist clinician at the back of the hospital can then listen to that patient's heart and lung and early triage and diagnose and assess the patient. And what's really exciting is we're bringing 2 healthcare professionals, but actually that doesn't stop there. Through using collaboration tools, we're able to bring in a multidisciplinary team conversation into this. So you could bring in the social worker, the occupational therapist, etc. So it's really that one NDT conversation around that patient. And I think you've heard Dave on the video say that it takes 15 years to actually train a doctor. And I think what's we're finding really quite exciting about these solutions is that these types of solutions, be it connected ambulance or remote diagnostics, can go some way to addressing that shortage of skills to be able to then get that remote clinical expertise out into the field with a paramedic, community nurse, community midwife.
I mean, maybe now's a good time for me to actually say that there's an opportunity for everybody to participate in this discussion. And if anybody on the line wants to use the chat button to put up questions, I can pick them up later on. But just to give you a little bit of a signal from where I would be keen to take this, is the kind of the rebuilding program we have in Northern Ireland during and post-COVID, but particularly the area of integrated care, particularly the area of rebuilding general medical services or primary care. As we reconstruct, would we reconstruct in the same way? And I think the nursing homes is a particularly good example of that. I mean, can we make absolutely certain that we've listened to some of the messages that are coming out of England, particularly around, and Andrew mentioned primary care networks. And, we have a rough equivalent of that as we go forward here. So I'm really, really keen to explore that as we go forward, but maybe that's for a wider discussion later. Andrew, are there any other points before I play in Janice Bailey? Are there any other points that you'd want to make?
I think, Tony, the one thing I would say is that laying all this out, it sounds relatively sort of straightforward. I think one of the challenges is with a system like ours, certainly just for people who don't know Birmingham well, and thinking about the care home sector. We have over 300 care home providers in Birmingham and Solihull. So, and they're all private provided. There's no statutory provision anymore. So when you're thinking about sort of developing these types of models, a lot of this is dependent on building good relationships with your partners. You can't just rush in and provide tech. Because that's where there's a high chance of failure and it not being adopted, and it has to be co-owned and collaborated and designed. And I think it's important for us when it comes to the care homes that we need to try and build it and set up a proof of concept with some care homes, but it will take time to sort of roll that out to have it really truly embedded, because it is such a fragmented sector in the UK and in Birmingham in particular.
No, I understand that. And Lucy, I suppose then that raises the question for a tech firm like BT. Is your vehicle into that private provision of nursing home care through a trust or through the NHS, or can you have a direct link in with some of the larger providers?
With this, it's all been about delivering the outcomes for UHB. What do they need to do? And it's all been very much about how can we help UHB take pressure off the system, take pressure off the A&E department, ensure that vulnerable, shielding individuals in the community get access to care, etc. So I think it's around, this is what the partnership's all about. We go together, and we've co-created this solution. We've chosen medical devices. They've all been approved and on the way by the clinical teams. We're working with clinical teams at UHB on this every day. And when we go out and do our proof of concepts and trials, this is all that we do together. And I think that's why it's been so important that it's BT and then the wider healthcare ecosystem. It's about us going together and engaging and being one joined up team. It doesn't seem right to me to be able to be going in and so I think we can obviously, from a care home perspective, we can support in wider connectivity if there are challenges there, but I think it's absolutely us going together, because it's a solution that's driving an outcome for that wider healthcare ecosystem.
Okay, thank you very much. I think that's a brilliant opportunity maybe to bring in Janice and just talk about the Northern Ireland context, because after that, then I'd be very keen that the three of you would maybe just talk about the opportunities for expansion or spread. I mean, how do we, if people are interested in what you're doing and can see the opportunity in a Northern Ireland context, how do they get into that? So I'll ask you to hold that thought until we've heard from Janice and come back on that. So Janice, thank you very much. Really looking forward to hearing what you've got to say.
I must say, first of all, that was a really exciting video with a really lovely piece of work by all you guys. So well done, and that's a great achievement. I mean, Northern Ireland, I was sort of asked, why is this so important for Northern Ireland? And we've always here in Northern Ireland had a strong culture of innovation. And innovation can mean different things to different people, even to those that are in the room today. So the R&D office where I work was set up in 1998 and has been a funder of high quality R&D for all that time. But we are also playing a leading part in the overall landscape of innovation here. And I feel that COVID has shed the brightest of spotlights on the role that research and innovation has to play in dealing with the new threats that are emerging to health and well-being. And it's not just COVID, there's lots of other things. So never before, though, especially with COVID, have I seen so much reliance being placed on the research community to provide answers to the unknown. And it's definitely an opportunity for change. And I must say that and I'm sure all of us have seen things moving at an unprecedented pace across the system during the COVID-19 pandemic. And then really is something that we mustn't lose during the next wave and indeed into the aftermath. So some of the things that I have seen happening during the pandemic in R&D and innovation have been some of which we have funded or participated in, but all of which have potential to be of benefit to us all. So zero prevalence studies that have been set up faster than ever in huge populations, both locally and UK-wide and cross-border in Ireland. More effective use of data for health and social care. For example, using data to examine the impact of COVID-19 on mental health through data-driven approaches, and work between colleagues in Public Health Agency and the board to further coordinate data streams. And we've also been able to bring in additional support from the Health Data Research UK Alliance, which we are part of. We've seen from our digital colleagues the development of new apps for symptom checking and contact tracing, with over 300,000 people signed up, and a unique young people's app that's just been launched. In the Northern Trust, we have the Medicines Optimisation Innovation Centre, which really blends research and innovation and has been involved in the development of very innovative medicines optimization approaches across different settings, using technology as a strong enabler to deliver pharmacy solutions across the system. And then the new UK-wide vaccine registry, through which patients can be recruited to vaccine trials and other research. And all of this has been underpinned by an improved speed of approval across the regulatory requirements to deliver research in the shortest possible time for improved outcomes, while still maintaining the rigor that we need. And it's all been delivered at a time when people have had little or no time, little or no face-to-face interactions. So the importance of digital innovation as an enabler in keeping us connected and delivering the outcomes has never been greater. And while there's undoubtedly been an impact on the delivery of research overall and normal services during COVID, the community has predictably responded with innovative approaches and using technologies to allow the delivery of research and services in new ways. For example, through delivery of treatments in the home setting and communication via digital consultation. So on the theme that Tony mentioned about working towards more integrated care, R&D and innovation has approaches there as well. I mean, we have supported research for years across the breadth of health and social care, but it's now increasingly happening across multiple settings, including anticipatory care, growing involvement of primary care in research through Northern Ireland-based and cross-border studies, research in care homes and community settings, public health and social care, and even most recently, we've been in discussion with the Northern Ireland Ambulance Service to start building capacity for research and with them as well, with the paramedics. So we have been playing, and we must continue to play our part here in Northern Ireland in the global fight against coronavirus. And we've already been doing a lot. And one of the things that we always say about Northern Ireland is that we can get all the key stakeholders in a room together. And of course we can, but sometimes things have been fragmented and change has been slow to happen. But during the last 9 months, I have seen big changes, people working together with truly shared purpose across all of the sectors, health, academia, and business in ways I haven't seen before. There have been new and important investments that we've made over the last few years. For example, in the Health Data Research UK Alliance, which has provided additional support for our data architecture, and the new initiative, which was launched last year at NICON and Bio, the Health Innovation Research Alliance Northern Ireland. Opportunities like the City Deals, Strengthened Places, and others are in the pipeline. And these have been in partnership with commercial colleagues, academic colleagues, and colleagues from health and social care. And most recently, I've seen these relationships intensify and grow. So obviously for us in health and social care, the most important thing is the patient, and they're at the centre of everything that we want to deliver. And last week, I took part in an interview with someone from Northern Ireland who received one of the new therapies under test for COVID-19 as part of one of the UK-wide urgent public health trials. Like many others who've participated in research, we're grateful for his participation and delighted that he had such a positive experience in such troubled times. For me, and undoubtedly for all of us today, this is the most important part of what we do. But at the end of the day, what's required, in my mind, to succeed in all of this is collaboration between people in the research and innovation community to deliver the best evidence-based health and social care for the population of Northern Ireland and beyond. So I'm really looking forward to the conversation that we will have. I know that we're very well placed to build on what we're already doing and learn from colleagues elsewhere and share the learning across the system. So thanks very much for inviting me today.
Janice, thank you. I mean, I picked up a few gems from you there, which if the conversation flags at all, I will pick up. But I have been, while you were talking, I've been busy reading the comments or questions that have come in from people. And there's several people have asked a question about technology first, which I'm going to go back to Lucy on. Can Northern Ireland support some of these initiatives? Birmingham being a big urban centre in the middle of England might feel a little different technologically to some of the rural parts of Northern Ireland. And certainly getting a 4G signal, let alone a 5G signal, can be a challenge. So I suppose several people have asked how dependent on this are we on good networks to be able to roll out some of the things that you're working on. And if then, I suppose the question is, if the technology is not there yet, when will it be?
It's a great question, and I think that was very much uppermost in our minds when we developed the remote diagnostics capability. As I mentioned, this runs on 4G, 5G, or Wi-Fi, so it's not dependent on 5G. We are, as you all know, we're all still in the middle of rolling out our 5G network. But we wanted to be able to, have that flexibility in terms of that network, be it, a Wi-Fi or a 4G for the remote diagnostics capability. So there are some elements on the connected ambulance, for instance, where on the haptic technology, which are more reliant on 5G, but there are lots of elements that can quite easily work over 4G or Wi-Fi. I think it was important for us to be able to, yes, we're working in Birmingham, but the ambulance trust or community nurses can go out into rural places. So with the kit, there is either a sort of trolley version that sits within a care home or a clinic, a care centre, but also there is a lightweight portable rucksack version which has its connectivity, it's almost connectivity bubble with it. So a community nurse, community midwife can go out and take the coverage with them wherever they go.
Okay, thank you. I think that picks up on that question. The other piece I wanted, I see James Nelson's come in, and maybe this is a question to Andrew. It's about any calculation of the cost effectiveness of this, Andrew. I mean, what's it costing you? And can you make the business case for this in real time?
In terms of some of the connections that we're looking at doing with intermediate care, which ultimately they're not numerous in terms of size. The actual kit is not ridiculously expensive. I think, Lucy probably will correct me, but you're probably looking at anywhere between sort of £3,000 and £7,000 for the kit that Lucy described, and there's a small element of ongoing revenue costs associated with that. But I think the view, certainly when we're starting and working with intermediate care and linking up care centres and community teams in Birmingham, that overall cost we expect, and obviously the evaluation will follow through, is that our ability to keep people at home, reduce hospital admissions, should be able to more than offset that investment in technology. The other area, as I said, is not just the patient outcomes, but the ability for us, as we're starting to think about how we join things together, what our future workforce looks like and skill mix, and where that happens, and what digital gives us as an ability to change that. I think there are some big benefits we think will be coming in as we start to rework, for example, our medical workforce across the whole of Birmingham. As I said, we probably are quite inefficient in the way that we lay that out. We have consultants based in wards in the community where quite often a lot of the patients don't need medical input. So how do we sort of reorganise things by using technology? And I think there's a lot of potential there.
I think you're right, Andrew. I mean, even just working with Dr. Zoe Werko and team, her team of consultants at the moment travel between the Queen Elizabeth and the Intermediary Care Centre to go and visit patients. This type of capability will prevent that travelling backwards and forwards and give Zoe and team that time back, that much needed time back. I think the other thing that's been really uppermost in all our minds over the last 6 months is the NHS, the staff at the NHS have worked tirelessly under such huge pressure. And it's really important to be able to also sort of give them some time back through this type of technology, because they're all working under such huge pressure, having to try and manage the COVID pandemic, and also at the same time as working through the backlog of elective routine, which I know is a real challenge for the NHS at the moment.
Could I just come back to you on this? I think it is, I suppose as a retired trust chief executive, I would look at this and I'd say to you, how's this going to affect the bottom line? I can see the real benefits in terms of saving staff time, maybe better outcomes. But Andrew, are you putting the business case back to your board for this? Or in terms of the evaluation you'll do of this work, will the business case be part of that?
It would, Tony. I mean, just in terms of the sort of pump priming of this, I mean, as a system, we've managed to secure some non-recurrent resource to pump prime the initiative and get it moving, which obviously is helpful. And really, as we start to roll out the phases of work, what's going to be quite key is the evaluation of that in terms of its effectiveness and delivery, in terms of outcomes, in terms of, and as you say, ultimately, the cost effectiveness of it. What that additional annual investment would be, and how that will be funded will be the subject of an investment case. But we're grateful we've got the opportunity to start it through some non-recurrent money that's been received.
There's one question in from Dan West from our Department of Health, responsible for technology in the north, and I hope I catch it. It's quite a long question, Dan, more partly a comment, but I want to capture it. is really, I suppose, demonstrating just that little bit of rightful cynicism that we've seen these ideas knocking around for a long time, and they're coming up with 5G. But what do you think have been the barriers, even with 4G and Wi-Fi, that have stopped this level of creativity before? And I suppose it comes back to the question we started with: why are you different? Why have you been so productive? And what is the lesson for us that will get us over a hump on this?
I think one of the reasons is, as I mentioned earlier on before, I think that some of these concepts have been around a long time, and some of the technology has as well. And so it's about putting it all together. And it's about that, I think it's not just about, the hospital trust doing something in silo. It's about everyone coming together and culturally being on that same page to drive this forward. Because what we're trying to do, it's about moving, where possible, moving more care from the acute, taking pressure off the acute out into the community. And to be able to do that, it's about bringing on board the ambulance trust, the care homes, the Birmingham community healthcare early intervention teams, GPs, etc. Everyone needs, and I think that's why this is proving to be such a successful piece of work, because everyone is on the same page and we're moving forward together.
I mean, certainly, Lucy, in picking that up, I think from a Northern Ireland perspective, one of the key levers for us absolutely has to be the drive to improve integrated care, particularly between primary and secondary care and into community care. And I think COVID genuinely is the backdrop for that. But even before COVID, we were driving initiatives on what we called anticipatory care, particularly in care homes, and on better integration with primary care.
Tony, it is amazing what you can do when everyone's on the same page. I'll give you an example. So when we were at the peak of COVID, the terrible situation where we had, people in intensive care, their friends and family were unable to visit, unable to say their goodbyes in some, very, very sad situations. And so there was an initiative that was kicked off by critical care staff at Guy's and St Thomas's. They brought us on board, and we helped sort of facilitate the deployment of video messaging out to intensive care units. And that took a matter of days, not months, because everyone was like, this is the right thing to do. We need to do it and drive it forward. And I think, over the course of, over a matter of 3 weeks, I think we delivered 1,100 tablets over to about sort of 200 trusts. So it just shows when you've got everybody together working towards that collective vision, what you can achieve in a short space of time, because there's a real, it's a joint outcome and that joint shared vision.
Absolutely great. And you segue very neatly into a question from Ian Stafford, which is possibly my favorite question, because it's something we actually talked about and you've just touched on, which is actually the problem in care homes of access to for relatives to their frail elderly. So in Northern Ireland, given our climate, we're still depending on window visits and garden visits for relatives to see their frail elderly family members, which seems to me verging on the barbaric. And I think Ian asked the question, are you in this space? You kind of hinted at that. But I suppose there's a little challenge back. Could you take that a step further and think about how you could actually materially affect the quality of life for people in care homes and their relatives in this area of contact?
Yeah, I mean, I spoke about the sort of Lifeline's intensive care video messaging capability. We have actually, since we did that, taken it to one step further, which is a proposition called Virtual Visitor, which is absolutely that, being able to connect people with their loved ones between, from a care home back to their friends and family. And as you say, we need to think about how we can maybe develop sort of virtual visiting pods within care homes, because it is so very important, that much needed contact. I know how unhappy I am not being able to see my mum and dad on a regular basis. Being able to have good quality conversations and quality time, is so very, very important. So yes, we are certainly, we'd say we've got our virtual visitor proposition, but also looking at what we can do in terms of developing some virtual visitor pods within care homes.
I know Dan West's on the phone or on the line. So Dan, I'm terribly keen on this, and it's an area that I think we might want to pick up outside of this. It's the idea that we've tended to focus on either no access or the quantity of access. and very little on the quality of access, particularly in care homes. And it does seem to me there's an opportunity here, either with BT or other tech firms, to actually move this one along very quickly. I'm beginning to run out of questions, folks. So if anybody wants to fire in another question, please do. While you do that, I might look to the panel members maybe to start thinking a little bit about how they would sum up here. So we've got just over 15 minutes, so plenty of time for everybody to come in. Or if anybody who's on the audience, Dan, for example, if you want to break in and actually speak, you're very welcome. But very keen to pick up on any specific points. But while you reflect on that, I'll just maybe go to Janice again. You've heard, and based on the conversation you've heard, Janice, any further thoughts from you?
Well, I think that it's been a very interesting conversation and around the whole digital provision, and I think digital tools are, of course, increasingly important for me, and I think this sort of agrees very much with what Lucy was saying. Everything really does rely on the people involved. There's three key things in my head that coincidentally, like COVID, all begin with C, but and you might say it's connectivity, but really connectivity enables all of these things. So communication is always key, and there's no point in doing all the great things unless they're communicated and shared through effective knowledge exchange. And I've seen that during the pandemic. Collaboration is, without that, we wouldn't achieve anything. And we're well positioned in Northern Ireland to ensure we can collaborate, again, back to people. But in terms of the main one for me as well, another really important thing is having the confidence, and we need to be able to proceed with confidence, knowing that we have support for research and innovation from the very highest level and throughout the system. Because we know from evidence that good health and social care is provided by organisations that research and innovate. So for me, we really just have to do this together, and it's the people that are key to making this work.
Janice, I've got a fourth C for you. I think culture, because I think that innovation and driving this forward, and that's what we really have, hugely from, Dave Rosser and Andrew and team, is that sort of, striving to continually want to improve, drive digital transformation, and that culture being cascaded throughout the team as well. I think it's really important.
If I can come in, because you've taken I was going to add culture as well. I think I've just come from a session this morning where we were looking at people's concerns around the changes that are proposed here to elective care and to emergency care. And a lot of the concerns coming through were from people about, what happens if you close the local emergency department? How do you know that you'll get treatment in time? And I think one of the issues there was to know that you got the right treatment. And I think those concerns and the reluctance for people to accept changes that we need to make the whole system would be assuaged to a large degree if people understood that they could go to somewhere reasonably local and kit would be there that would triage them. And if they needed to go helicoptered or real blue light run to the Royal because they have a particular kind of stroke or a bleed into their liver or whatever, that would happen. But if, on the other hand, turns out that's not what's wrong with them, and that can be diagnosed accurately and rapidly close to home, then they'll be happy. I mean, nobody actually wants to go on a blue light run to a hospital just on the off chance. So I think there is a great deal, picking up with what Janice has been saying about the need for communication, but it's actually communication not just within the HSC system, but it's communication outside to the public, to the service users. They have to buy into this too. And I don't see that being a difficult sell. I think it would probably be an exceptionally easy sell, really. But then that takes us back to, are people confident that this kit will actually work in places in Northern Ireland, which, as Tony said, don't really have good mobile communications, if any at all. And so, you know, it does sort of go round in a circle, but I think the push to make this happen is actually going to come from our need to get the transformation process to work. Because I think the big stumbling block there is going to be people won't buy into that, and it won't get support from the public and therefore support from the politicians unless these public concerns can be dealt with.
Which Christian, I think, raises an interesting question for Lucy and Andrew. In terms of the work that you've already done, because you're well down the journey, are the public with you? Are they ahead of you? Or are they actually behind? I mean, I could imagine if they've had a good experience, they might well be ahead of you, but I'll be interested in your views.
Well, I think where there are areas where there is often sort of conflicts around potential hospital reconfigs, there's always a natural starting point of suspicion and cynicism. I mean, in Birmingham, we don't have that backdrop, but what we found is actually patients, for example, where we've set up links around older people to our front door teams, that's people having the ability to have an assessment remotely in their own home, and to then have some confidence that actually if they do come into the front door to accident and emergency, they are coming because they really need that. And that actually alternatives are given to them that are available now in this way of working, where the specialist team can ask, you know, either do a full assessment and suggest some sort of follow-up outpatient appointment, or linking with the GP to pick the patient up the following day, or to reassure and have a discussion with the family over the video with their loved one around. Just giving reassurance quite often to carers that actually they're okay, and just to observe, and also most importantly to leave that assessment with an escalation route for the patient and the family, so they feel that they're not just left, they actually have a clear number, a clear single point of contact if there's a problem. And often that's always the challenge, is often we don't leave that, and then people get very frustrated because they're never quite sure of the route back into the system, or the appropriate route back into the system. We've also been able to send out rapid response teams with advanced nurse practitioners to do more detailed assessments, and I think that's enabled people wherever possible to remain at home. And once people feel that system is coherent and confident, that they have a route if they feel it isn't working for them, then clearly most people are actually really enthusiastic about it and see that there are real merits and benefits, because in most cases they are able to stay at home and remain at home and receive what they need if they need something in their own home.
Thank you, Andrew. Lucy, any further comment on that?
No, Andrew just said exactly what I was going to say, actually. I think that, bringing in, I talked about multidisciplinary team and collaboration in the MDT at the hospital, but that can also, as Andrew said, works the other way. So you're bringing, maybe for a dementia patient, you can bring in their friends and family and take everyone on that journey as well. So I think just to sort of, bring the patients in that way and take them on that journey.
Okay, thank you. And maybe just continuing on a kind of summing up and final reflections, Andrew, do you just want to maybe give us your reflections, particularly as a hard-pressed operational director in a large trust? I've got your sense of enthusiasm about this, but I'm really genuinely interested in and where in your head, in your quiet dreams, where you think this is going?
Yeah, I guess I've been I've been in operational management. I'm not in operational management now, but I was in operational management for about 25 years. I was chief operating officer, and I was chief operating officer sort of at a time really when we started in England to see some really big spikes in emergency admissions. And I've been down in A&E, and I still go down, although not as much. But the patients that come in, the level of comorbidity, often frailty, that actually you just think actually we've got to be able to do this better. And quite a lot of people, once they are in an acute hospital, often remain in an acute hospital for a significant period of time, and it's that is not a good thing in terms of their ability to recover. And quite often there are things when you talk to the front door teams that actually, well, if we had access to so and so, or if only we'd known, or if only we'd had a chance to talk to the relatives, this could have been avoided. And I think to be able to start to use digital technology to connect up all aspects of care, to connect professionals to families and to patients in their own homes, I think is just really exciting and has there's a real transformational opportunity that I think is good fundamentally for patients and the public, because that's what we're here for, but can really allow us to make sure that we truly do deliver care in the right place. And the reality is that too much care has been sucked into the acute over the years, and somehow we have to address that, because that is an unsustainable position.
No, fully accept that. Lucy, I was going to give you the last word here, if you wish.
What I'm incredibly excited about is really this proof of concept, this prototype solution that we've got is just the start. And we've got a digital stethoscope ECG, and for us this is just the start. And we're really keen to work with wider trusts on co-creation, co-developing solutions. And so I'm really looking forward to the future in terms of what that holds.
Lucy, it's Richard Eccles here. If I can just step in. So I work for BT alongside Lucy as well. I think the technology side from us, it's the easy bit. It's you guys that do the real stuff in the field, and is the difficult bit. Getting people to change and embrace change is the really hard thing. I think 5G from 4G is a massive change. It's not just like copper to fiber. It's not just about faster network. We can put 1 million devices in a square kilometer. So that's somebody with assisted living having lots of different things monitored and measured in real time, real high latency that you wouldn't get in any hospital network. So it's complete change. But we just talked about some of the possibilities. We're for a tremendous change in Northern Ireland with Encompass. Really stepping up the digital transformation in community care. All that information, all that data then can be collated and pulled back, and that will continually drive transformation. And that's a really exciting place to be. 5G
rollout. Where are we on that? And I'm not just talking about, within Greater Belfast, but across the rest of the province. I mean, is this something we need to be pushing for as a big infrastructure project that needs to be done?
We go where the largest population is first. So I don't know exactly the number of cell masts and coverage that we have in Northern Ireland as yet. There's quite an aggressive rollout plan as we're switching off some of the older 2G and 3G sites, and they're being migrated across into the newer 5G. Interestingly, somebody mentioned about coverage. There's parts in Birmingham that don't have 2G and 3G coverage as well. You're never ever going to have 100% coverage with any mobile provider or with all mobile providers. It's just something that mobile is not going to be able to provide. So, and there's always going to be a coverage, and there's always going to be not spots provided. But there's a very aggressive rollout. EE were the first ones in the world to ratify and develop and to launch 5G. So we're doing it as quick as we can.
Firstly, can I thank Andrew, Lucy, and Janice? I think we've had a really good discussion. We managed to overcome the formality of doing this online and still make it feel spontaneous. So well done. I do think I have a sense from this presentation, and also the drive in the province at the moment following COVID, but also in terms of the transformation agenda that already existed, that there is an opportunity to get over some of the inertia because there is a need. So I'm going away from this presentation really quite optimistic, for which I'm very grateful, and thank you, everybody.